Good morning and good afternoon, wherever you're logging into. We are at the top of the hour, so I think we will get started. Got some lovely numbers of people signing in, so why don't we get started? I'd like to welcome everybody to today's webinar hosted by the Canadian Coalition for Seniors Mental Health, who I will refer to as CCSMH going forward today. My name is Betty Watson-Borg, and I am the project manager for the Social Isolation and Loneliness in Older Adults Clinical Guidelines Development and Mobilization Project. That's a very long name. And I am here today with my team members, Anna, Lisa, and Peter, who will be in the background supporting our webinar, and I will be your host and facilitator for today's session. We are absolutely thrilled at the interest in today's topic with over 880 people registering. And thank you for being here today and sharing some time over a busy day and a busy time of year. Just to note that for people who registered and were not able to attend directly in person today, a recording of the webinar will be sent out in the next couple of weeks. So we're happy to share that information for people that registered and are not able to be with us here today. And also, as you'll hear in a moment, we will be using the chat quite actively, and we will be curating the content and information and resources from the chat, and we'll also be sending that out to all registrants as a PDF. So welcome to our webinar series, From Awareness to Action, Igniting Ideas for Addressing Social Isolation and Loneliness in Clinical Practice. And we're thrilled to be doing webinar 2 of a 3-part series on exploring screening tools and assessment. We're excited to be able to share as well. If you would like to be listening or reading along in French or another language, we do have the Wordly app. You can use the QR code and you can have that content simultaneously translated in written form for your listening and reading accommodation. I'd like to start by sharing the mission of the CCSMH is to promote the mental health of seniors by connecting people, ideas, and resources. And CCSMH is a program of the Canadian Academy of Geriatric Psychiatry, which we call CAGP. And appreciating CCSMH is a pan-Canadian nonprofit organization and that you are logging in from across this wonderful country. And so we would like to acknowledge that the work of these guidelines takes place in many Indigenous territories, including the traditional and ancestral homelands of First Nations, Inuit, and Métis peoples. These territories may be under treaty, unceded, or contested, and we are committed to advancing reconciliation and equitable health outcomes for all Indigenous people. And we invite you to reflect for a moment on the traditional lands in which you are joining us from today. All right, there we go. We have a busy lineup for you today. So just to do a quick review of what's going to happen, I'll be taking a minute or two to do a brief overview to CCSMH and the development of the clinical guidelines. And then we'll be very pleased to share the stage and the podium with our 2 panelists today, Kari, who will be talking about some screening tools, and Dr. David Conn, who will be speaking on assessment. This being said, at the end of our time today, we do want to have some time for some knowledge exchange because you are in the field and you are spending time working with older adults. So we would love to be having you think through this webinar today. What are the opportunities and challenges you are experiencing when integrating screening and/or assessment for social isolation and loneliness into your practice with older adults? So we'd love you to have that question, that reflective question in the back of your mind as we go through today's session, and we will really love to hear from you. And at the end, we do have a QR code that we would love to find out from you what was helpful for you in this webinar. We're always interested in continuous learning and learning from the people that we're spending time with. So before we jump into content, we would love to find out who's out there. So we would love to find out who's in the audience and where are you located. So my colleague Anna is going to put the first poll up and would love to get a sense of, okay, our first question is, what is your professional role? We have 2 poll questions. So let's just take a moment to see who's in our audience. Look to you, Anna, to let us know when we've had a sense of time for people to do the first poll.
I think we'll get a couple more seconds. We've got about 84% participating.
Oh, fantastic. Drum roll.
Okay, I think we'll launch now, Betty.
Okay. Da, 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 da.
All right.
There we go. Now, because this is a big list, you may have to scroll down. Use your cursor on the side. So we have 8% administrators, 7% community organizations, 4% educators. We have a nurse, a licensed practical nurse, registered nurse, nurse practitioner, occupational therapists, recreational therapists, go team. We have a physician welcome, a psychologist, researcher, social services worker, and social worker, and then other. We always have to apologize for the other because we don't want to minimize all the amazing professions and work that other professionals are carrying out in this area. All right, let's put up the second poll to find out cross country's checkup. Who is in the room? I don't think we actually have an other, do we, Anna? If there was someone from out of Canada, do we?
I don't think so. If you're
Yeah.
international, we'd love to hear about it in the chat.
Yes, yeah.
Give it a couple more seconds, Betty, and then we'll end this one.
Over to you whenever it feels like it's complete.
Okay.
There we
There we
go.
go.
All right. Alberta, British Columbia, Manitoba, New Brunswick, Newfoundland, Nova Scotia, Ontario, PEI, fantastic. So we have folks from across Canada and we don't have our north. So we're always looking for contacts in this world in the north. So if you have some connections and contacts in this world, social isolation and loneliness in clinical practice, we would love to have those contacts. So welcome to everybody across Canada. For those of you in Nova Scotia, that's where I am. We've had some really crazy weather today, so I'm happy that you had power to log on today. All right, thanks so much, Anna, for that poll, and let's just keep moving forward in our slide deck. Just a few notes in terms of how we want to use both the Q&A and the chat. So if you have any logistical questions or any tech-related questions, if you can use the Q&A. And then to help facilitate the knowledge exchange portion throughout the webinar and at the near the end when we are actively engaging with you, we would like you to use the chat and write out as much detail as you want, particularly in relation to the question about how is screening and assessment showing up in your practice. And then we would love to hear a few other voices. So if you'd like to share verbally, if you can use the icon to raise your hand, my colleague Lisa will be monitoring raised hands and we will open your mic for you. We apologize, this webinar Zoom setup means we have to open up your microphone. So we would love to hear from a couple voices. So please use the chat liberally and use the hand raise if you would like to share something. And we're really looking forward to the wealth of knowledge to be shared. And as mentioned, we will be curating the chat content and getting that back out to all registrants. I'm going to be sharing just a little bit of background information, and then I'll be passing it over to our speakers. But before I carry that on, I would love to introduce our two amazing speakers. First of all, we have Kari Med, who will be going first. And Kari is a practice director, provincial recreation therapy, allied health professionals with Alberta Health Services. Kari holds a degree in recreation administration from the University of Alberta with a focus on special populations, and her clinical experience includes acute and forensic mental health as well as rehabilitation medicine. Throughout her career, Kari has been committed to advancing professional practice that enhances health, wellness, and quality of life for individuals, families, and caregivers. And we met Kari and well over a year ago and is definitely a champion for social health. Our second speaker, it's a delight to introduce Dr. David Conn, who is a professor at the Department of Psychiatry at the University of Toronto and a geriatric psychiatrist at Baycrest, also in Toronto. Until recently, he served as the Executive Vice President of Education and Chief Academic Officer at the Baycrest Academy for Research and Education. And we're so fortunate to have David with us, as David was the founding co-chair of the Canadian Coalition for Seniors' Mental Health, which was well over 22 years ago. So David is definitely one of the other champions in this area. And David has been the past president of the Canadian Academy of Geriatric Psychiatry as well. And David was also the principal investigator for the development of the first ever clinical guidelines on social isolation and loneliness among older adults. So a true champion, and I'm excited to have them share the stage in just a moment or two. So just a little bit of background information. If you were on webinar one, you would have heard these couple slides. So we apologize if it's a little bit of repeat, but there may be some new content. So just a reminder, CCSMH in action, 23 years, and we work in close collaboration with the Canadian Academy of Geriatric Psychiatry. And really our focus is collaborating with interdisciplinary professionals that form the coalition, whether it's clinicians, academics, and communities in various fields, conducting research and staying at the forefront of emerging knowledge, translation on mental health and aging. And one of the primary products and outcomes of the work of CCSMH is researching and providing evidence-based guidelines and education opportunities to support you as you support the health of older adults in their care. So check out our website. All of the clinical guidelines are there on our website, downloadable. And we're very proud in 2024, we launched the first clinical guidelines in the world on social isolation and loneliness in older adults. Why? Why is this important? Why have we gone down this path? You know, I think coming out of the pandemic, I don't think there is anybody out there that didn't experience themselves or with family members or friends the impacts of extended loneliness or being apart from those we love and care about. So this is becoming very evident through research and through lived experience that social isolation, loneliness is an important health factor, and that the unwanted social isolation and loneliness experience impacts not only our emotional well-being, but our overall health outcomes, including physical health and increasing the risk of mortality. And we've learned that healthcare and social service professionals, that we have shortened to HCSSPs, in so many cases are already supporting their older adult patients or clients as they navigate aging and health. And we're hearing too many stories that in some cases, the HCSSP may be the only contact, social or otherwise, for an older person. So we want to recognize, acknowledge, and celebrate the work that you do in this area. And we also wanted to try to provide support, resources, information, so that we can feel like we're working together. So this webinar is intended to spark reflection and ideas to continue to navigate this together. Before I pass it over to our speakers, just reminding that social isolation and loneliness are often put together, including by ourselves. However, social isolation does not always mean loneliness. We can be lonely in a crowd. Having more social contact does not automatically reduce loneliness. And it's possible to be alone and not feel lonely. And that feeling of solitude and being by ourselves are also some of the contributing factors that we need to take into consideration. So just a reminder when we're talking about this that they are connected. However, they're both unique and distinct experiences. So today with our speakers, we've asked them to share with you their knowledge and insights on both screening and assessment. And we've asked them to keep in mind today's case. So we are going to put this more detailed case into the chat so you can see the PDF. But just a quick review, we have Carol, who's returning to her family physician of 2 years. And she has some things on her mind that she wanted to talk about while getting her shingles vaccination. And you can see a little bit about Carol's demographics, her age, some other information, and some health considerations. So I am now going to pass our podium over to Kari, who's going to take us through the recommendation on screening and share with us some insights and experience. So welcome to you, Kari.
Thank you, Betty. I'm really pleased to have this opportunity to be part of this webinar series. So I'll get started and we'll just have a look at the recommendation number 5, screening tools. When screening patients or clients, healthcare providers should use evidence-based screening tools to identify patients or clients who are socially isolated and or lonely, to assess the severity of the problem, and to use in routine follow-up to determine whether the patient's or client's social situation has changed and whether interventions are effective. So we know that social connection is critical for health and well-being, and addressing these factors can improve health outcomes. Because of the impact of social isolation and loneliness can have on health and well-being, it's important to routinely assess using validated tools so that changes can be tracked over time. Routine follow-up and measurement can help to determine whether the problem is chronic or transient and whether interventions are working to improve a patient's social connection. We also know that loneliness can carry a stigma, and some individuals may not recognize isolation as a problem, making sensitive screening and discussion essential. The importance of screening is that it offers opportunities to provide education to patients on the importance of social connection and inform them about available support services. So let's have a look at the recommended scales within the clinical guidelines. If we can go to the next slide, please. Wonderful. Look at you.
Okay, it's there. Good.
Thank you. Thanks. So there are 7 screening tools identified in the clinical guidelines, and most screening tools measure either social isolation or loneliness, not both, and research to develop and test tools in clinical settings continues. There's no single tool that's recommended for clinical use at this time. The UCLA Loneliness Scale measures loneliness indirectly, and this is the tool that we'll dive into a bit more over the next few minutes. This is the one that we are using in Alberta. But before we do, I'll just briefly go over the other scales recommended within the clinical guidelines. So the single item loneliness scale is just as it states, it's a single question during the past week. How often have you felt lonely? The next UK Campaign to End Loneliness scale is 3 subjective questions. The De Jong-Gierveld Loneliness Scale has 6 indirect questions that focus on both emotional and social loneliness. And the CARED Social Isolation and Loneliness Referral Tool was developed for health and social service professionals to quickly determine if a person is socially isolated or lonely and whether they should be referred to other services. The Lubin Social Isolation Scale is a self-report measure on social engagement, and the structural social isolation scales looks at 5 indicators of social isolation. So we'll dive into the 3-item loneliness scale. Next slide, please. So across our provincial health agencies, we use an electronic medical record system called Connect Care, and the entire UCLA 3-item loneliness scale is reproduced with permission and available to all staff, including our allied health colleagues and nursing. When working to identify which tools to include in the system design, our recreation therapy team identified the 3 ILS because as you can see on the side, the questions don't specifically ask about loneliness, but they still get to the root of whether a person is experiencing loneliness. This helps to avoid any feelings related to stigma while still noting there's a need to have established a rapport with an individual before diving into asking those questions, as we would with any interaction that we have with the clients and the patients that we work with. So if we think about today's case, Carol is returning to see her family physician, and we can assume that there's already a relationship established prior to exploring social isolation and loneliness. Next slide, please. So more reasons to choose the tool. Our role as recreation therapists or as any healthcare or service provider is to improve well-being and quality of life for individuals. And we know that social isolation and loneliness has a serious impact on physical and mental health, quality of life, and longevity. before we can make a difference, we need to be able to recognize the risk factors and screen for social isolation and loneliness. This tool provides the opportunity to have conversations and support people to live their best life. It's easy and it's brief, as noted, with only 3 questions. It's patient scored, so we do have the voice of the patient, and that reduces any assumptions that we might have as a clinician or as a social service provider. Importantly, it's evidence-based, and as noted, the tool doesn't outright use the term lonely or loneliness, and it's free. It's free to use, so there's no cost to the services that we provide. So if we think again about Carol's demographics and her health history, she'd be a perfect candidate to be screened. She's feeling low energy and has reduced interest in gardening, and she has risk factors that include her age, that she's female, a lesbian, and has major life transitions, including a partner in early stages of dementia. She's retired, and her support network is reduced with living rural and a distant relationship, and she has a distant relationship with her brother. So how do we approach this conversation with Carol? So when we had a webinar for our teams in Alberta, many of the responses that we had as to why people are not beginning these conversations that were related to asking about social isolation and loneliness, the responses were that they just don't think about it, or they're not sure about what solutions to offer, or they might just feel awkward. And sometimes, people were thinking that it just depends on the person. And in my opinion, I think it really depends on the clinicians. Patients don't know what they don't know, and it's really our responsibility to be asking the right questions to provide the right services. So I think it's fair to say that a rapport has been built with Carol's family physician, and being brought back in for further discussion opens the door for an honest conversation about the concerns that would lead the physician to ask a few more questions. It's an opportunity to normalize, offer support, and discuss the benefits of social connection, and the potential for has the potential for reducing some of the prescription medication and the impact on her overall health. Yeah, next slide, please. So in Alberta, we are using the tool and recording data for geriatric psychiatry, palliative day hospitals, transition units, subacute, and community. We've had the most uptake in geriatric psych and day programs. By using the tool and tracking progress, we can hopefully improve quality of life and help people stay in their homes longer. If you would like, please add to the chat any areas that you might think suitable for use of a screening tool. Where are you using it? And are you using any of the other tools? So you can go ahead and drop those in the chat if you like. And we'll go to the next slide, please. So I see someone's using it in long-term care. That's great. Yeah, you might think that in long-term care people have people around them, but yet can still experience that loneliness and social isolation. So really great. So some of the benefits that we've identified in using the tool in Alberta here is we're able to note whether the interventions have made a difference and how it aligns with other data elements such as pain or falls. If we can get someone up and moving to connect, we've increased their mobility and possibly in turn improved their strength and balance, which can reduce their falls. And we also know that stimulating the mind with social interaction and creative expression can also reduce a person's perception of pain and discomfort. So based on Carol's health history of osteoarthritis and being on the wait list for knee surgery, her pain and falls may also be tracked and noted to identify if there's any changes in her pain or frequency of falls within the interventions provided to reduce social isolation and loneliness. Ultimately, she might just be better prepared for recovery from her surgery with an improvement of her experience of pain. And these may be conversations points to be explored based on her responses of social isolation and loneliness. The bottom line is the opportunity the tool provides to have a discussion and offer education and other resources to improve well-being and quality of life for seniors is of utmost importance. So I see we've got it being used in intakes in the community, social prescribing at the adult day program and in seniors residences. So it's nice to see that it's being used across different sites and different programs. So that's a wrap for me. I might have gone a bit quick, but back to you, Benny. Thanks.
That's perfect. Thank you so, so much, Kari. Lots of food for thought there. Whoops. We have another poll before we move to Dr. Conn. So we'd just like to do a little check-in with you. How likely are you to try using a screening tool in your practice with the older adults in your care? Hopefully you see the screen, this poll on your screen about screening. Sounds like from the chat, we will have a few people already using it in their practice across a diversity of settings. That's amazingly wonderful. Thank you.
Let it go for just a couple more seconds, Betty, and then we'll
Okay,
the
drum
results.
roll.
All right.
There we go. Look at this, folks. Or your innovators, your uh, front edge leading leadership. That's fantastic. Terrific. All right. Thanks for that. Thank you so much, Kari. That was so interesting. I know I've got at least 3 or 4 different takeaways from your practical experience working with your colleagues in the system. All right. It's my pleasure to introduce my colleague, Dr. David Conn, and I'm just going to move that slide forward and away we go. There we go.
Thanks, Betty, and thanks, Kari, for giving us so much information about and useful information about the screening process. And of course, screening is the first step, a critical first step. As I always say, don't ask, we don't know. If you don't ask about loneliness, there's no way of actually knowing if a person's lonely or not. And I'm a fan of short screening instruments like the UCLA 3-item, but also the 1-item loneliness tool. During the past week, how often have you felt lonely? That's you don't need a lot of time to ask that one question, right? So when it comes to assessment, these are the formal recommendations within the guidelines. So the first is a thorough clinical assessment with a patient client who is socially isolated and or lonely should aim to explore the possible causes and identify any underlying health conditions that may be contributing factors. Other causes that may be contributing should also be identified adopting a biopsychosocial approach. A comprehensive assessment can guide the development of an appropriate management plan. The assessment may, of course, vary according to the healthcare and social service professionals' scope of practice. Next slide, please. So I love this slide, and the question is, well, what is the reason that a person is depressed? What do they think? What do we think? Some people just don't have any idea about why they might be depressed, but a lot of people have a good reason, or maybe several reasons. And the same question applies to social isolation and loneliness. So what is the background cause or causes that we can identify? Next slide, please. So just to emphasize the biopsychosocial model that we use always in our educational efforts with students and trainees, it's to look at a person from a unique and comprehensive holistic approach, recognizing that there may be social and environmental factors, psychological factors, and or physical biological factors that all may be working together or combining to affect a person's overall health and mental health. So that's the lens that we need to look at, not just thinking about a single cause. Next slide, please. So within the guidelines, there's some hints about what is a comprehensive assessment, and we outline things that should probably be considered, recognizing that, you may not have an enormous amount of time. So this is, if you're doing a whole new assessment of a person perhaps and have the time, we should understand the medical history, the social history, mental health, cognition, other cognitive issues, screening for substance use, understanding the person's environment and finances, and of course their family, any recent life events. So this is critical because for many people, there are changes, transitions that have a huge impact on isolation and loneliness. Looking at overall lifestyle, because that may be something that we can really focus in on in terms of prevention and improvement, and then overall insight and motivation for change. We should never forget that there are some people just may not be motivated for change. But hopefully that most people are interested in some kind of change that can improve things. But sometimes people need education to have that insight. We also mentioned that utilizing a strengths-based approach can help identify an individual's positive attributes and protective factors while avoiding stigmatization that can result from deficit language, ageism, images of dependency, etc. So, when we're doing a history and we're looking for problems, we also should be looking at the strengths that a person has as well. That's really important. Next slide, please. I think Kari has made some great comments about our case vignette, Carol. So just a few other thoughts. So we know she's retired. We don't know what was her occupation. How relevant is that now at this point? And when did she retire? And how did she feel about retirement? And how is her partner's dementia impacting their life together? Is she depressed? So there are certainly hints of that. And if she has significant persisting depression, not just a bad day, but persisting depression, a clinical depression, then how can she be helped? And of course, we have so many interventions to help someone who has a significant depression, ranging from psychotherapies to, in more severe cases, actual medication, antidepressants. So that may be critical if indeed she is depressed. And as Kari said, what about her mobility, her activities, and pain? Does she and her partner have friends in their community, in the LGBTQ2S community, or in the larger community? And are they involved in social activities? All these thoughts and questions that should be running through our mind in a case like Carol's. So, and I'm just thinking about pain, how critical that is. And in a way, loneliness is psychological pain. And if you think about, if we take a person who presents to our clinic or our setting with pain, we want to assess that. There are all sorts of questions we ask about the pain, right? Including, when did it start? How long have you had the pain? What helps the pain? What makes it worse? We should be thinking about loneliness in exactly the same way of really trying to understand it. Next slide, please. This is from a table that's in the guideline document, which of course you can get from the CCSMH website. And this is just examples of where the assessment, the history, can link to the intervention or multiple interventions and things that we might want to consider. So, for example, sensory and communication impairment. This is a big one, right? So if the person is having serious hearing issues or visual issues that are uncorrected, or the person has hearing aids but has decided for whatever reason that they don't want to use them, then that could be a critical intervention, right? It could, because, if you can't communicate, that really compounds isolation. So managing chronic medical conditions. What about if there is cognitive impairment? That is often associated with a person doing less in their life, being able to do less, and that may be a critical focus. Next slide, please. And of course, understanding the person's social history and lifestyle. What is their social network? What was it? What is it now? What hobbies and interests do they have? Are there financial issues? What about their lifestyle? Do they actually get any exercise, or are they very sedentary? And are there transportation or environmental barriers? So looking at all of these things may, in fact, tell us what are the most critical interventions. And then, of course, mental health, critical. So as I said earlier, is there underlying depression? Is there underlying anxiety? Because that can be a huge issue as well. Certainly people with social anxiety, maybe that's been a lifelong condition that's never been really addressed or helped. And of course, CBT, cognitive behavioral interventions, or other psychological therapies may be really important for someone who has such a problem. And then understanding recent significant life events. Has the person lost a critical person in their life, perhaps their spouse? Are they going through grief, bereavement, and need help in that regard? So all of these are ways of really trying to understand the person's unique situation. And I think that's the main message, of course, here is that we start with screening, and then we want to do a full assessment to truly understand the person, and then figure out what are the best interventions. And there are some fantastic interventions like social prescribing. And I know quite a few of you online today are involved in social prescribing. It's absolutely fantastic. It's almost certainly going to help anybody, but it may not be the only solution that we have to consider, the only intervention. So, yeah, next slide, please. Okay, so I don't know if any of you have heard of Highway 50 or where it is, but it is renowned as the loneliest road in America. Why? Well, it's actually in Nevada, and it's about 400 miles long, and there's virtually nothing on that road. So it's considered to be the loneliest road. And in Canada, we have lonely roads too. And which is the loneliest road in Canada seems to be a toss-up between the Trans-Taiga Road in northern Quebec or the Trans-Labrador sections of the Trans-Labrador Highway. But my point here is that it's a journey. Loneliness is a journey. We need to understand the unique journey for that individual. I'm reminded of the lyrics from the band Green Day in the Boulevard of Broken Dreams, where they say, "I walk the lonely road, the only road that I have ever known." Okay, that's a perspective, right? Not really a sense of despair, just a sense of that's who I am. I'm a kind of isolated person, and if someone wants to walk with me, that's okay. But unlike maybe other lyrics from pop songs, like "My Loneliness is Killing Me" from Britney Spears, which probably would suggest something else is going on. But my point here is that, there are different ways of thinking about this. And there are people who will tell you they've been lonely their whole life. And clearly that the intervention there needs to be different from someone who's recently experiencing loneliness for a whole variety of reasons. So I think that was my last slide, so I'm going to stop there, and I think we're going to open it up.
Thank you so much, David. That was amazing in the time we had. So we have another poll. Not dissimilar. How likely are you to include social isolation and loneliness as part of your assessment? And appreciating we have such a diversity of people, practices, environments, contexts. So we'll just a little bit of check. What's coming up for you here? How likely are you to include social isolation and loneliness as part of your assessments? Maybe next time we'll have the Jeopardy music on at the same time.
Just give a couple more seconds, Betty, and then we'll be good to go.
Yay.
Okay.
There we go. Look at this. We've already got almost a quarter already including it. That's amazing. And we got lots of interest, somewhat likely, 10% likely, and very likely. So hopefully you've been able to take away some nuggets of insights and experience from Dr. Conn, and the guidelines have a lot more detailed information for your consideration. All right. Now we'd like to turn it over to you. We're calling this the Knowledge Exchange. And as mentioned at the beginning, we would love to hear from you, see from you, both in writing in the chat, as well as we are really interested if there's some folks out there that would love to raise their hand, and we can open the mic and hear more directly. We love your voices. So the reflective question, or what are the opportunities and challenges you're experiencing when integrating screening and or assessment for social isolation and loneliness into your practice with older adults? So knowing that we had 22% that are already working in this way, would love to see what's coming up for you, what you're experiencing, and those of you that are thinking about it, love to know what you see as the opportunity or what might be some challenges that you're facing, you think you'll be facing on the horizon. So I'm going to turn the mic over to my colleague Lisa, who is able to monitor the chat, which we found to be very busy, and share some of that information, and to open the mic with colleague. And yeah, David and Kari are going to come on the screen to hear as well, and field some comments and observations as well.
Perfect. Thanks, Betty. And if you are willing to chat, maybe send us a message if we don't see your hand, saying that you would like to have your mic unmuted. That would be great. I just want to highlight the comment that Marjorie shared, where she said, I once taught a man in his 50s how to read. He said something to me I will never forget. Now I feel like I belong. So a lack of reading skills may indicate loneliness. That's an excellent, excellent sharing. So thank you very much. I'm wondering too, as people think about screening and assessment, if you can share how you've managed to integrate that into your practice. We have such a great percentage of people who are doing this work already. We would love to be able to, for you to share that with everybody on the webinar today.
Lisa, I see a question from, I hope I'm pronouncing your name correctly, Sudeshna, and she's asking about whether there's some bias in the questions and whether the seniors may be providing socially desirable responses. So whether there are other scales or tools that might be complementary to the UCLA 3-item loneliness. So I guess, noting that the 3ILS is a loneliness scale, you could also use one that is more focused on social isolation. And I also think that this is, it's a screen. So it also provides the opportunity to ask further questions like Dr. Conn had mentioned. So it's really an opportunity to open the door and have the conversations. What are some of the other questions that you can ask beyond what's stated in the scale? So, and I think the other piece is the importance of having that rapport and having those conversations about why you want to be asking these questions so that they do feel like they're in a safe space and they can answer honestly and they know why you're asking the questions. So I don't know if you wanted to add to that, Dr. Conn, or anybody else, but
Yeah,
those are
Kari, I
my
think,
thoughts.
yeah, well, that's absolutely critical, I think, is the context and the kind of
Mhm.
relationship you're establishing with the person and making the person feel comfortable and trusting. And yeah, rather than just launching a series of questions at someone, exactly, that's so critical. And often in a primary care setting, the person already has a good relationship, a good working relationship with their client, their patient. So yeah, I think that's critical. And I still wonder about why we're so sheepish about actually asking about loneliness. And I always mention this, but Dr. Frieda Fromm-Reichmann, a psychiatrist back in the 50s, said that we just simply avoid this topic completely, and notes that it just is barely noted in psychiatric textbooks and as reflected in the DSM-5, where there's only one mention in 1,000 pages. And it just seems to be something we're afraid of almost universally, right? It's so painful. But my experience clinically is it's okay in the right context to ask people if they actually feel lonely. And sometimes I'm really surprised. And sometimes people spontaneously bring it up, and I'll be quite surprised. So, yeah.
Excellent. Just going through the chat here, there's so much rich information. being
which we
shared.
capture, right,
Yeah.
Lisa? We don't be afraid. We keep all of these valuable comments.
Yeah, we do. That's a great point, Dr. Conn, is we do compile the chat and we'll be sending it out with the recording at the end of the webinar.
If there's anyone who's interested in unmuting and sharing verbally, save a little bit of hand time, would love to hear from you. So just raise your hand and our colleague will open the mic up for you. We'd love to hear your voice.
I just see a comment about communication as well, and that hearing impairment and aphasia are a couple of really large challenges. And so, that is a big thing in our world is how do we communicate with people and make sure that we're hearing what they're saying, whether that's through visual means. So having the tools, like you say, a pocket talker, maybe having a pen and paper available, having the responses and the questions written out. So that they can maybe point to their scaling, whether it's a 1, 2, or a 3 um, on the 3 ILS, for example. So yeah, that's a really important challenge to highlight and be prepared for. Thanks, Anne Marie.
So many great comments in here. I'm just struck
Yes.
by Wendy Roberts' comment about how dialysis creates social opportunities as people are together 3 times a week or more. So people with, a chronic medical condition, often alone, perhaps, or isolated, are brought together for treatment and being with other people, with staff, with other patients. What a great comment there. Just so many different perspectives on this topic.
Dr. Conn, I'm wondering if you can address Christy Hunt's comment. I currently use a Pieces. Sorry, I just lost it because it's the chat is going. But the Pieces assessment.
Yeah.
Let me just find it here. Sorry.
I see it.
Yeah, I see it.
Yeah, I'm just wondering if you can speak to that there's a piece missing about motivation.
Yeah, no, then the right. Yeah. So I mean the piece is an excellent framework. It's a Canadian invention and it's used a lot, particularly in long-term care, although it's useful in any setting, and it really does, as you say, Christy, that it really takes a biopsychosocial perspective on trying to understand and assess a person. But yes, you're noting that it doesn't really address that issue of readiness for change and motivation for change. So absolutely, I agree completely. And the comment Christy also mentioned that how we support care partners is just as important as they also report feeling isolated and lonely, and that's so true. Care partners are often, for obvious reasons, particularly caring for someone with dementia, they become very isolated and lonely and need tremendous supports. And we often forget that when we're, focused on our individual patient. Couldn't agree more.
I'm just looking at the most recent comment from Mariah about working on a project with paramedics in New Brunswick. This is such an interesting group because they're often the first point of contact. And I'm wondering if either Kari or Dr. Conn would like to comment on that group.
I think I was going to say the role of paramedics seems to be expanding a lot, which is tremendous because they're a fantastic resource, both in acute situations, but beyond when they're not actually responding to acute emergencies. So I really love this idea of paramedics being used and assisting much more in the community when they're available, and I think that's a fantastic approach.
Yeah, I can just add on to that, and I don't know if it's Maria or Mariah, but in Nova Scotia, particularly in Cape Breton, you might want to connect to those folks because they've initiated the community paramedics is now the new terminology, and their goal is to keep people from getting in the ambulance and going to hospital. So completely reframe, like it looks like it's happening in New Brunswick. So Nova Scotia Health and community paramedics, and they particularly have been working in Cape Breton for a couple of years.
I just wanted to bring your attention to Molly's comment about the recommendation of the Red Cross's Friendly Calls program. And this is a tremendous program. And Just unlike, or also like the United Way Canada 211. So, a lot of opportunity for people to reach out and connect with people.
Yeah, I think those friendly visitor programs, either in person or virtually, are tremendously helpful for isolated folks. Yeah.
Yeah, team, if we haven't put the 211 link in the chat, we may have already done it, but we're always surprised that not everyone is familiar with 211, which is a one point of entry. It's across Canada, pretty much every community, with locally sourced resources, programs, services, etc. And it can be a really handy place to either refer your clients or patients to, or help them navigate that as well. There we go. And it's been around for about 20 years at this point in time. So we're really interested in sharing that word.
So many great comments in the chat and tremendous work that's being done across the country to address this issue. It's fantastic.
Yeah, I was noticing that there are some comments when I was asking about what tools are you using, and I just wanted to make a comment about it's not just the use of one tool, it's the incorporation of several tools and assessments to get to the root of the problem. These are some of the tools, but I think in combination, it's really important to think about incorporating them. So when you're using the pieces, you can incorporate some of these loneliness and isolation tools as well. So they all work together to help get to the root cause and do some problem solving with the people that we work with.
I just want to address the comment from Anna Maria, who says, from the trenches, it seems to me that your interest is more in curative health rather than working hand in hand with preventative health.
Mm.
Our guidelines try to emphasize the whole first section is actually on prevention. Our first webinar was more focused in that realm. But so it's both. We definitely want to see prevention as well, and identifying risk factors, early interventions, and keeping people as healthy as possible as early on as possible. So yeah, no, we don't want to underemphasize a preventative health approach as well, and focusing on positive lifestyle changes. Absolutely.
And preventative measures from people going to hospital as well, or moving into long-term care. So yeah, that point well taken, Anna Maria. Thank you.
I really, really like the comment about focusing on the individual's personal assessment of whether or not they feel lonely. That's an important consideration.
And there was a great comment earlier about the approach of what matters most to that person. I love that. I mean, that's critical. It's not what we think is the most important thing, it's what our client, our patient thinks is most important to them, always.
Just building on that comment earlier, I think that we're all saying earlier because we saw it earlier and it's so far up in this massive, rich knowledge chat was the unintended consequences of language and wording. And so sometimes with questionnaires of saying, kind of positioning being by yourself as kind of a negative thing in contrast to being with others or participating. So that's kind of note to self around the language we use, particularly when we're asking people. Because as mentioned earlier, the value of solitude, spending time, reading a book, doing crafts, being in nature by yourself, etc. So that's just a kind of note to myself as we look at language and wording that we're not inadvertently bringing some of our biases that being lonely, being by ourselves is always a negative thing. It was way up there. I apologize. I can't give the contribution who said that. And so we're coming up to the top of the hour, everybody. So we would like to thank you for your time and interest in joining us today. I know the team just cannot wait to get back into the chat and see all the amazing things that were coming out. We would love to hear your feedback and insights about today's webinar in terms of the content, the learning opportunity, as well as any improvements for our next webinar, which is going to be in January. So the QR code is there. The link is going to be put into the chat. And we will also share that link when we send you the recording and the curation of the chat. We'd like to do a little bit of a advertisement for our next webinar, which will be the third of the series, which is really a lot more about interventions. Dr. Michael Rutledge will be focusing particularly on social prescribing, which came up today, and Rhiannon Buffett, who is also a recreational therapist. She's deciding which interventions she's actually going to bring to the webinar. So we're going to keep you guessing, and we hope you'll join us in January. And if you want to stay informed with CCSMH, you can go onto our website. You can sign up as an associate. There's no charge, and then you'll automatically get information that's coming out about this initiative and all the other initiatives that CCSMH are working on. And one final little advertisement, we're in the process now of phase 1 of a national campaign to do exactly what we just did. We want to hear from you. What practices are working in your practice with older adults and patients and clients? And so we're going to put that link. The timeline is this Friday, so we would love for you to participate in our knowledge exchange, and there'll be more coming out about that in January. So thank you, everybody. You've been an amazing audience. Thank you to our guest speakers, Kari Med and Dr. David Conn, and we hope you have a great rest of your day, and we look forward to staying in touch. So thanks for that. Bye for everybody. Bye now for everybody.